Okay, so good evening again, everyone, and welcome to our webinar. This evening we'll be talking about pancreatic cancer and what treatment is available when surgery isn't an option. Just as a reminder, this session is for anyone affected by pancreatic cancer, whether you have a diagnosis yourself or whether you're supporting a friend or family member who's had a diagnosis. You're very welcome. This session isn't aimed at health professionals, but there is a wealth of information on our PCUK website, which talks about some upcoming webinars in September and October. My name is Rachel Richardson, and I'm one of the specialist nurses here at Pancreatic Cancer UK. I've been working at the charity now since the end of 2017, and before that I worked as an upper gastrointestinal nurse or upper GI nurse in a hospital, and I looked after people diagnosed with upper gastric cancer, of which pancreatic cancer is one. Day to day, my job at Pancreatic Cancer UK mostly involves supporting people impacted by pancreatic cancer by our support service. And moving on to what we'll cover this evening. So we're going to talk about chemotherapy, radiotherapy, and how to keep as well as possible before, during, and after treatment. And then, as I've said, we'll have a good amount of time for a question and answer session. So my two nurse colleagues, Lynne McCallum and Lea Booth, will be leading this evening's session, and they'll both introduce themselves as we go. I work alongside both Lynne and Lea on our support line here at Pancreatic Cancer UK. So I'll now hand over to Lynne, who will be starting our session. And as I say, don't forget, if you have any questions, please do put them in the Q&A tab and share any thoughts or experiences via the chat. So over to you, Lynne.
Thanks, Rach. And hi to everyone joining us tonight. I know I can't see you all, but it's so great that so many people have joined us. My name's Lynne, as Rach said. I'm one of the nurse specialists here at Pancreatic Cancer UK. I've been involved with the care and support of those affected by pancreatic cancer for about over 20 years. It's shocking when you say it out loud. And during that time, I've supported patients and their loved ones as they embark on treatment, during treatment, and after their treatment. I was an oncology ward nurse first, and then a chemotherapy nurse and chemotherapy sister. I've been a nurse specialist for over 15 years, firstly as a HPB or hepatobiliary a neuroendocrine nurse specialist at the Christie up here in strangely sunny Manchester. And I joined the team here at Pancreatic Cancer UK in 2017. You could say chemotherapy is one of my specialist mastermind subjects. So it's my pleasure to be here chatting to you all and to be kicking off tonight's webinar with some discussions around treatment for incurable pancreatic cancer. I wanted to make this session as helpful as possible. So throughout this, we will be sharing our thoughts on useful things that you will want to discuss, or you might want to discuss with your team involved in your care. But tonight is also an opportunity for you to share your experiences and top tips with each other. So if you, throughout this, you may think that you want to, I've got some interesting tips for that. You might want to just pop that in the chat like Rach mentioned. And Rach also mentioned that at the end, there'll be of our talks today, there'll be a Q&A session. So keep adding these as we go. And just to reiterate, no question is stupid. So there's lots of pieces of information that need to come together before treatment can be planned by your oncology team. These bits of information include things like scans, bloods, biopsy results, and how well you're feeling. This information is brought together and discussed at something called a multidisciplinary team meeting. You'll often hear this called an MDT. These are usually based at hospitals where the surgery happens, but your local hospital will feed into these meetings as they know you best, and they're supporting you through your pathway. As with everything, weighing up benefits and burdens is essential, and this allows you to make the best choice about what's right for you right now. Remember that this is your treatment, it's happening to you, so it's important that you and your family feel part of the decision-making process. I wanted to take a little moment here to ask you a little bit more about this. So if you're having treatment or you're about to have treatment, I wondered if you'd be able to answer the question that's on the screen. I'm hoping that you can all see that. So if you just click the button, I'd be really interested to have a look at your answers. I'm going to give everyone 30 seconds or something. As long as 30 seconds when you're waiting, isn't it? So, and that's interesting. Thank you for being so honest with your experiences. And I think what you're experiencing is something that I would see is quite common. So people have said that they're feeling more, a little prepared, not prepared, somewhat prepared, but not very many people. Only 16% have been well prepared. And that, I think, is something that we would say is quite common. So thank you. So what is chemotherapy? So chemotherapy or chemo, which is likely I'm going to use the term chemo through this talk, is one word that describes many different drugs. And it's usually given by intravenous infusion. Sometimes it might be given as tablets. And its job is to kill cells and control the cancer. And we want treatment to be systemic. And what I mean by that is that we want to give chemotherapy that kills pancreatic cancer cells wherever they may be in the body. And this is why we use chemotherapy to treat both locally advanced disease and metastatic pancreatic cancer. I wanted to highlight tonight the drugs that are commonly used to treat pancreatic cancer so that you are familiar with the words that you might hear in your consultations and perhaps want to talk to your family and friends about. It can be very confusing, all the different names of the drugs. And often as healthcare professionals, we love abbreviations, don't we? So, which doesn't help when trying to understand what's going to happen. So you might hear things like gemcitabine and capecitabine, which is on the list there, being called GemCap. Or you might see Braxane, which is on the list there, Gemabraxane, being called nab-paclitaxel. So I wanted to just bring into focus the medical jargon a little bit and give it a bit of clarity for tonight's talk. You can see that we use different drugs in different combinations, and we call these combinations regimes. And one full dose of treatment is called a cycle. Your team should give you information about your treatment options, and you'll need this bit of information before you're able to make an informed choice about what the best option is for you. We've already touched on the need to weigh up benefits and burdens of treatment. The benefits being that chemo can control the cancer, it can improve and maintain quality of life and extend life. But chemotherapy is a blunt instrument. In truth, we don't know exactly how chemotherapy might be for people. And so we must give people information about its burdens before you start it. I would expect before starting chemo that you're given written information about the regimes. So that's the types of drugs that's used, what their names are, how it might be given. It's also important to discuss things like how many hospital visits you might have with each cycle for bloods and checkups and scans and things like that. Most importantly, you need to understand how chemotherapy might make you feel, its side effects, and how we might manage them. I'm not going to labour on about this too much right now, as Lea is going to talk about this in more detail in her talk. But what I will say is that we've got loads of information on our website about chemotherapy and side effect management, which you can take a look at and digest as you need. It's sometimes hard to make sense what all this means for you. And of course, you can give us a call on the support line with any questions that you should have. And this is the final thing for me. I'm not speaking very much tonight in presentation mode. That's good. It's a final thing for me tonight, but I was really interested to hear from the people who are sat and supporting someone with pancreatic cancer. So if I could ask loved ones, be it partners, carers, friends, sister, brother, work pal, whoever you might be, if you're able to answer this question and just tell me a little bit more about how well prepared you felt to be able to support your loved one through their treatment, that would be great. So thank you for that. And again, I don't know if you can see the results. They've just popped up on my screen. But again, what you've experienced is something that maybe myself, Rachel, and Lea have also witnessed in our jobs and on the support line that, you know, somewhat prepared, tiny bit prepared, not prepared at all is quite common. So thank you. So thank you for being so open and sharing your experiences with me. And that's it from me tonight. So I'm going to stop sharing my slides. I'm going to hand over to my lovely colleague Lee for the next part of tonight's session.
Thanks so much, Lynn. Great insight and into your wealth of experience of what chemotherapy is, the typical treatment regimes, and the benefits and burdens of chemotherapy. Now, let me share my screen. Hold on one second. So my name's Lea Booth, and I'm another of the nurses, one of the newest one to join the team. And I work on the support line with Rachel and Lynn at Pancreatic Cancer UK on the support line. I joined here at the charity a year ago. And my role prior to this was as a HPB, as Lynn so eloquently put, but hepatobiliary clinical nurse specialist at a specialist centre in the West Midlands. I've also been a research nurse within the speciality of liver and pancreatic cancer, and I started my nursing career as a chemotherapy nurse 14 years ago on an inpatient ward, giving chemotherapy to adults, including young adults and children, teenagers. But enough about me. Let's continue thinking about treatments for incurable pancreatic cancer. Look at radiotherapy as a treatment and keeping well. Please continue to share your experiences in the chat, and any questions you might have, pop them in the Q&A. Okay, radiotherapy. Radiotherapy is a treatment given either on its own or together with chemotherapy to treat locally advanced pancreatic cancer. There are two types of radiotherapy, first being external beam radiotherapy and stereotactic ablative body radiotherapy. Good job I've got my teeth in because that can be a bit of a mouthful. So this is often called SABR for short. External beam radiotherapy is given with oral chemotherapy called capecitabine, which is a tablet you take at home. This makes cancer cells more sensitive to the treatment, so helps it to work. This type of radiotherapy has been used for many years. SABR is a newer type of precise radiotherapy. You may have heard it called CyberKnife. It's typical to have at least 3 months of chemo before SABR, but you don't have the chemo during the treatment. I think it's important to say the effectiveness of both of these treatments are very similar. SABR delivers higher doses of radiation in a shorter time, which reduces the number of days people must go to hospital, and the more precise field of treatment can potentially reduce the side effects. External beam radiotherapy is widely available, however SABR is only available in a few hospitals in the UK. So what are the benefits and burdens of radiotherapy? The benefits: the treatment can be quite quick. For external beam radiotherapy, it could be as quick as 15 minutes each day, whereas SABR takes a little longer and sometimes it's 30 minutes or more, but this isn't every day. Your radiotherapy will be as an outpatient and there's often fewer side effects than chemotherapy. It treats the cancer and it helps with symptoms. What are the burdens? There can be side effects such as tiredness, sickness, and diarrhea, but they tend to be mild when experienced. If having chemotherapy combined with radiotherapy, the side effects may be more prominent. The burden can be daily travel to and from the hospital, which might add in increased tiredness, especially the more treatment sessions you have. Not everyone can have radiotherapy. It does depend on the size of the cancer and the location, or where in the pancreas it is. Wanted to have a think about what questions might be useful for you to ask your team when you're discussing treatment. Remember, clinic appointments are your time. Go with a list of questions. There aren't any silly questions, as Lynn has already alluded to. And if you're worried about something or you do not understand something, please ask. You also don't have to wait to be in clinic to ask questions. You can seek advice and support from your clinical nurse specialists. And of course, you can get in touch with us here at the charity on the support line. So our top 10 treatment questions are shown. What are my treatment options? Why am I being offered this particular option or options? What are the benefits of the treatment and what are the burdens? How many visits to the hospital will there be? And can I have treatment closer to home? How will the side effects be managed? Who is my point of contact in the team? Who will be my emergency contact when I'm on chemotherapy? And are there any other treatment options than the one that's been suggested? When I mentioned with number 6 about can you have treatment closer to home, sometimes there are some satellite places that offer chemotherapy. Hence, it might not be in the centre where you go in the tent clinic. So that's why it's always worth asking, is there something closer for me? Okay, so sorry, I went a bit too quick. I think I was trigger happy there with my fingers. So this is probably my top tip to you all too, with thanks to Chris. Now, keeping well. I strongly believe that keeping well is something that should be woven throughout your pathway and should be a priority for you and the healthcare professionals involved in your care from the point of diagnosis onwards. I'll spend a little more time now chatting over some things that I thought might be useful for you to think about, not just for before starting treatment, but for during and after treatment also. Before doing that, I just wanted to know your thoughts with the next poll question of what you think is important in preparing for treatment. And remember to pop any questions you might have in the Q&A. Here we are, here's the poll. Oh, thank you so much for being so honest. And I'm not surprised all of the above. A lot of people have their own personal experiences and thoughts on how they should prepare for treatment. And absolutely, I think all of the above, but even more so in each individual case for all that have been mentioned. Okay, thank you for that. So, preparing for treatment. I know that waiting to see the oncology team to discuss treatment can feel like an anxious time. People often describe the feeling of just wanting to get started with treatment as quickly as possible. However, we know that taking some time preparing for treatment can really help you to be as well as you possibly can be before embarking on it, and by taking the time to focus on your well-being can help you to improve and maintain your quality of life, which may in turn help you to tolerate treatment better. Being seen by oncology in a timely manner is very important, of course, but use the time between appointments as an opportunity to work with healthcare providers on tackling the symptoms of pancreatic cancer. We know that focusing on diet and digestion is a proven for people with pancreatic, is a priority, beg your pardon, for people with pancreatic cancer, coupled with exercise and emotional well-being that's been proven to keep people well before, during, and after treatment. Wanted to share some thoughts on how to keep well on treatment. Before starting treatment, ask how will this treatment make you feel? There are common side effects which we'll touch on in a moment, but you should be given written information on the proposed treatment, and you can also find detailed information on our website on treatments for pancreatic cancer. Ask how are the side effects prevented? Often the commonly experienced side effects will have preventative medications. You must take these as instructed, and if they don't help, tell someone. Managing symptoms of pancreatic cancer alongside any side effects that you might experience from the treatment, and if you're able to, keep a diary on how you're feeling. A diary is a great tool to help you and the healthcare professionals look back and see any patterns of symptoms and side effects that you experience. Side effects do need to be managed proactively if they can, but what do I mean by this? Often there are patterns to side effects. For example, your chemo may make you feel sick, but you've noticed that this is only on days 3 to 7 after the infusion. By keeping a diary on how you feel and a pattern emerging, I would suggest taking additional anti-sickness on days 3 to 7 to prevent the issue. Prevention is better than cure when it comes to side effect management. But if you are still experiencing side effects, even with increased management, do let someone know. Discuss how you feel with your team at every review. Call your clinical nurse specialist to discuss any non-urgent worries or concerns you might have. And again, remember, there are no silly questions. If you're worried about a side effect, ask. Your team will be able to offer ways to manage side effects, but they can only do so if they really know how you're feeling. So, common side effects of treatment. We know that treatment can cause side effects. Some are common with chemotherapy and others are a little more specific to the individual drugs and treatment. Nausea and vomiting is a very common side effect of chemotherapy, and anti-sickness medications are often provided for during and after chemo days, sometimes before as well. If they are not working, it's important to let someone know. Diarrhea and constipation is another common side effect of chemotherapy, but sometimes it's other medications such as the anti-sickness tablets that also affect the way your bowels work, or not. So it's not unusual for your team to tweak, adjust and change your medications to keep on top of the side effects. So a low blood count. I think Lynn mentioned earlier about how chemotherapy works. So by attacking the cancer cells, but chemotherapy can't distinguish the good healthy cells from the cancer cells. So a very common occurrence is low blood counts. Chemotherapy affects the bone marrow, and this is where the white cells and red cells are produced. When attending for pre-chemo bloods, your team may say you can't proceed with the treatment this week. You've got a low blood count. But which ones are low? If you're not sure, please do ask, if you want to, of course. It might be the white cell count and the neutrophils that are low, and they're the ones that fight infection. Or your red cells, perhaps your platelets, the ones that help you clot to heal the cut quickly, or your hemoglobin, the cells that carry the oxygen around your body. The suggestion, if any of these are low, might be to have a week off treatment, and this is quite common, to allow the bone marrow and bloods to recover naturally. If this is a regular occurrence with low blood counts, a dose reduction of chemotherapy may be suggested. It's a normal and safe way of managing the side effects of low blood count. So, sore mouth and taste changes, very typical alongside a low blood count. The white cells that fight infection, if they are low due to chemotherapy, can allow the normal bacteria in the mouth that lives there quite happily and in the digestive system to go a bit berserk. And this can show itself as a sore mouth, as mouth ulcers, or as oral thrush, perhaps. Prevention is better than cure, and mouthwashes are commonly used to prevent the ulcers. And if you have a strange taste in your mouth, have a look at the inside for signs of oral thrush and any changes. Any doubts, then call the 24-hour chemotherapy hotline for advice. The next three on the list are more specific to certain drugs. So that cold sensitivity and tingling of fingers and toes, the sore hands and feet, and sometimes a reaction. So if at any time during treatment, if you feel unwell or you feel not quite right, let someone know straight away. All of the potential side effects and how they are treated should be discussed and explained in detail by your oncology and chemotherapy team prior to you starting the treatment. So as much as I can share with you my thoughts and top tips when thinking about keeping well on treatment, I think it's always so much more valuable to hear from people who have personal experience. So I'd like to share with you a short video clip from Claire and Bradley, where they share their experience and thoughts on chemotherapy and treatment.
If things are going wrong, is not to be frightened if your doctor suggests getting the dose reduced. You know, we were terrified of that happening, and actually, you know, thinking back to those first 2 doses of FOLFIRINOX that you had, which absolutely trashed you, and then you had it reduced down to like 60%, and the difference was astonishing. And interestingly, the first routine scan you had after that still showed that it was having some effect. But it meant you didn't end up on the chemo ward with neutropenia for 2 weeks. Being prepared to have those discussions with your doctor and to take your doctor's advice is really important, isn't it? And I think that the key thing here, the theme is about assumptions. So it's that assumption that it's only going to be a 100% dose of FOLFIRINOX that's going to work. And, you know, it was suggested to us after your third bowel obstruction, whatever it was, that actually there's no way you could continue with FOLFIRINOX. It's just way too toxic for the bowel. And GemCat was suggested, which, you know, we were thrilled that there was another option, but we were advised this probably won't do anything. You had a year of that, and for 7 or 8 months of that, you know, the CA19 just came down, and, you know, you did really well on it. And so it's about not having that assumption that there's only one thing that's going to work.
Thanks so much to Claire and Bradley, and I'm sorry if there was a little interruption at the start. So, helping to keep you well. What help is there available to keep you well with an incurable pancreatic cancer diagnosis before, during and after treatment? At the top of the list, Pancreatic Cancer UK, where we can offer you support to help you keep you well with sessions like tonight. We have a wealth of information on our website too that you can utilise as and when you need or want to, and of course our support line services as well, which I'll tell you about these in more detail shortly. Palliative and supportive care are two words describing the teams or services of care and support that are available to keep you as well as possible from the point of diagnosis onwards. You might already be aware of or have thought about some of the help available to you, and you might have had the opportunity to talk with your family, friends, nurse specialists and oncology team about these too. If you're not familiar with palliative and supportive care, how can you access this or these? So the local cancer support centres such as Maggie's, we're a charity that has a number of centres dotted around the UK that tend to be on the sites of hospital grounds. They offer psychological support, complementary therapies, support groups. Some have tumour disease specific support groups and networking groups as well, and financial advice. There's lots more too. I've only mentioned a few areas of support they offer. If there's not a centre near to you, then they do have some online support available also. Another brilliant resource are the Macmillan Information Centres. They're usually found within the hospital where your oncology team are or where your chemotherapy is administered. They can provide information and support for you and your family from a local perspective, advising what's available in your area to keep you well, and that might be local support groups such as a walking group or a gardening group perhaps, and complementary therapies as another example. There again is likely much more that they can offer. Be worth a visit to see if it is on the site of the hospital you attend, and you could tie it in with before or after your pre-chemo bloods or at your next clinic appointment. So the emotional and holistic and social support may well be best served by the teams and centres just spoken about. For the medical support side of things, to keep you well, that would be via your hospital team, which includes your oncology team, your clinical nurse specialist, perhaps your dietitian if you have access to one, and your GP practice, who might suggest and have access to district, community and Macmillan nurses who can support and help to keep you well. Your local hospice, often when I discuss the hospice, people can feel a little alarmed, and because I think we often associate the hospice with death and dying. Whilst the hospice does support people as they approach the end of their life, the hospices these days focus on supporting people to live as well as possible for as long as possible. And a key component of this is them offering proactive symptom control, which can be done as an inpatient, as an outpatient, or in the community. Let's hear from Claire and Bradley again, who are going to let us know their experiences of accessing support.
So I think one thing that we
Top tips.
haven't mentioned that we should mention is about engaging with palliative and supportive care and not being frightened of that, understanding the difference between palliative care and end of life care, because they're quite different things. And I think if we hadn't engaged with a fantastic hospice, our life would have been much the poorer, wouldn't it? You know, thinking about,
Oh golly, yes.
you know, the complementary therapies, you know, the counselling that you've had. I've had some family support sessions. We had a community nurse that came to see us. She was brilliant. The psycho-social and spiritual support that can help to keep you well, as long as the actual acute medical interventions. And I think it's both of those things that keep you bobbing along. So I would really encourage people, don't be afraid of engaging with that, because there's so much it will enrich your life.
So thanks to Claire and Bradley for sharing their experiences again. People can often feel anxious when treatment finishes, and there can be feelings of uncertainty about what happens now. Often asked, why can't I just carry on with treatment? And it's a very reasonable and understandable question. Everyone is different, but it is common for people to have a break after they complete 6 months of treatment and be placed on something we call active surveillance. This is a period of time when you're not going backwards and forwards to hospital, and you can focus on recovering from treatment and hopefully have some normal-ish life. But this might feel a little odd after such a long time of frequent hospital visits and close observation. You should check with your team about what the follow-up is for you. It might be that this is a good time to ask about what happens next. Perhaps what's the next treatment? and might this include a clinical trial? I think it's important to know that when treatment finishes, it doesn't mean the care and support ends. Often the care and support that will be most beneficial to you after treatment finishes isn't based at the hospital, but is based closer to your home, as we've touched on tonight. When on active surveillance, keeping in touch with your team via the clinical nurse specialist is key. If there is anything you're uncertain about, or if you have a new symptom, letting someone know is really important. I want to share with you some of our support information that includes the support line telephone number, as you can see on the screen, an email address that comes straight through to the nursing team here at Pancreatic Cancer UK, and of course our website. Rachel, Lynn and myself are 3 of the 7 specialist nurses on the support line during the time shown, and you can contact us in the way that suits you best. You can also catch up on some of our previous webinars on demand. Some may be relevant, like the diet and pancreatic cancer and diabetes and pancreatic cancer, and the other ones, living well to the end of life, pancreatic cancer and emotional well-being. You can dip in and out as you wish. Circles, that's our online community space via WhatsApp and Facebook. Please use the QR reader on the screen or the webpage link to find out more and sign up to connect with others currently affected by pancreatic cancer. There's a few groups at the moment that are running that might be of interest. So some take-home tips from Lynn and myself and Rachel, and all of us on the support line, I guess. Treatment is different for everyone. Do keep asking questions. Keeping well on and off treatment is a priority. Keep a diary of how you feel. If you have side effects, treat them straight away. Call the 24-hour hotline for urgent advice. And the 24-hour hotline might be called the Acute Oncology Service or AOS. It's usually a mobile number or one direct to the hospital, and it's 24 hours a day, 7 days a week. Treatment breaks and dose reductions are normal and helpful. Quality of life is so important. Prioritise yourself and each other. Make sure that you know who to contact if you have any questions or need advice, and get support from the right people at the right time. So before the Q&A, this is the final poll. We really appreciate if you could to join in with this one as well. Great to know how confident you now might feel after tonight's session about talking to your team and family about your treatment plan. Okay, so somewhat confident, feeling confident, and some very confident, with a couple that are not so confident. So a couple of percent. I think if there's anything that you'd like to know more about, or you would like to delve a little deeper into some of the information, because we only have a certain time period today to talk about the treatment options, please, by all means, give us a ring on the support line or contact us by email, and we could perhaps go into more detail to give you a little bit more confidence, and we can go from there. But thank you for being so honest and answering the questions. That's the end of Lynn and I speaking. Thank you so much for listening. Now I'll hand back to Rach.
Oh, thanks, Lee. Thank you, Lynn and Lee, both for your fantastic presentations there. Really great to hear all of that. And yeah, just to really reiterate that if you have very specific questions that you'd like to talk through about your experiences or what's happening now or your concerns now, then please do make use of our support line. It would be a real pleasure to talk to you, or we're also on email as well if people prefer that. Okay, so we're going to fire ahead now with the Q&A. So we've got sorry, lost it there. And we've got a few questions. Some of them are quite sort of short and sweet, so we'll try and whiz through as many as we can. And if you do have questions, then feel free to pop them in the Q&A box. So if we start with this one from Jan, maybe if this one's for Lynn, how often should I have a review with the oncology team?
Oh, that's a good question. And Jan and everybody in the room, so to speak, it can be different for each place, each person, depends where you are. But for me, you should have a review by somebody before every single chemotherapy cycle. And that may be over the phone. You definitely need bloods before your chemo. But yeah, I would say that you need a review by somebody before each cycle of treatment, but it might not be your consultant, it might be a team member. But that's so that you can see you, they can look at your bloods, and they can assess your symptoms, side effects and symptoms of the cancer, because we need to manage those alongside each other. They go hand in hand. But yeah, and they can assess things and make adjustments and have a conversation with you about what the next steps might be, or, carrying on with treatment, whatever that might be. And that's why Lea touched on it, and I'm going to touch on it again because I think it's a really key point, is keeping a note of how you feel. Because I find when you get reviewed in between cycles, people have sometimes forgotten how they might have felt last time they had treatment. And so, I can get that. So keeping a note helps me, helps the people who are looking after you, know how best to proactively manage what those symptoms are and prevent them happening again. Which is a very long answer to a very short question, so I do apologise.
No, thanks. And do you think I know you said a review by somebody, not necessarily a consultant. Do you think you should be seen by a member of the medical team or a consultant?
So I think you should be seen. So it does depend in each centre. So but you should be seen by, it might be in the medical team, but sometimes it's every other cycle. But you should that's why you have the point of contact, your key worker, your nurse specialist. So if you aren't due a follow-up consultation, sorry, I got a hair in my mouth, you can speak about getting added to the clinic list. But for my experience, in my practice, we saw people every single cycle before their treatment. But I know that is different in different places. So asking that question right back at the beginning of this session, you'll remember we talked about asking questions. That would be one of the questions that I would be asking. So having treatment every 2 weeks. Am I seen in clinic before that? Is it the day of treatment I'm seen, or am I seen on one day and treated the next day, which is common because of the nature of how many people and how long FOLFIRINOX, for example, takes. So yeah, they're the key questions. But yeah, ideally for me, you should be seen before every treatment.
Okay, thanks, Lynn. And then we've got another different Jan. If this one's for Lea, we've been told my husband will have chemotherapy for as long as it is working, rather than a specific time period. Is that common?
Yes, it can be quite common. But what would tend to happen is that there will be a scan done at usually a 3-month time point, and as long as the scan shows that there's no extensive disease, or it's not grown too much, or hasn't spread anywhere else, or perhaps, then continue with treatment. And so it can go on for longer than 6 months. But it depends how you are as a person, how you're coping with treatment, how well the treatment's working, and other variables as well. So it is a conversation definitely to have with the oncologist about what their length of time, although how long's a piece of string, but it can be for longer than the suggested, what we said this evening, of 6 months of treatment, perhaps, in my experience.
Thanks, Lea. Okay, and we've got a question from Enya. How can we limit risk of infection? My mum has just got out of hospital. She's had 1 dose of chemotherapy and she's ended up getting sepsis and pneumonia. Am I right to come to you, Lynn?
Yeah, absolutely. Right. So it's a great question, and it's something that people are often worried about. So again, taking our minds back to what we've been talking about a little while ago, chemotherapy attacks cells. It affects good and evil, if you like. And one of the good cells is the white cells and the neutrophils. They're the 2 cells that help your body fight infections when they crop up. So when you have chemotherapy, you are at more risk. Everybody who has chemotherapy is at more risk of picking up an infection than if you weren't on chemotherapy. Most people will pick up infection at some point. So it used to be, when I first started giving chemotherapy, when it was all in black and white, in the olden days, what would happen, we would say, oh, you've got to restrict what you do, you've got to minimize your contact with people, but it didn't really work. And actually what we find is most people will give themselves the infection because of the we're covered in bacteria. We've got bacteria in our mouths all the way through us. We're touching things all the time. So the things that we can do to minimize the risk of infection is good hand hygiene. We used to say, think about food, cutting out anything that is traditionally giving people food poisoning, upset tummy. And that would be something like, and it may not be something you're familiar with for everyone in the audience, but a pregnant lady diet. And so the things that we would say is you want to reduce the things that have got active bacteria. So all the tasty, stinky French cheese, it's tasty and stinky because it's got bacteria that makes it lovely and tasty and stinky. But we want to minimize that. So on chemotherapy, we want, you have hard cheese is fine, cheese spreads are fine, but we want to avoid the non-pasteurized stuff, bries, the Stilton, the blue vein stuff. Yogurt's fine, and things like that. Milk is fine, obviously. Seafood is okay, but no crustaceans, no bottom floor sea dwelling creatures. So, and things that traditionally prawns, crustaceans, oysters, and things like that. And thinking socially, it's really important that people on chemotherapy are able to socialize as normally as they possibly can. And again, in the black and white days when I first started, we used to minimize people's activity. Absolutely. Didn't really help, to be honest, and actually restricted people's quality of life. So we soon went away from that. But again, if people are covered in awful gunk, because that's sort of, got colds, diarrhea, ask them to stay away. Good hand hygiene. Don't be restricting kisses and cuddles with the grandkids, but children and grandkids are covered in germs, and that's fine. But just good hand hygiene, but don't wrap yourself. So minimizing the risk is key. Avoiding at-risk activities, and food groups and things like that, and being mindful. And if you feel unwell at all, and it doesn't matter if it doesn't feel like it's an infection, take your temperature. And if your temperature is above, usually it's 37.5, but you'll check with your team what it is locally, and in the middle of the night. So have a thermometer in your bedside cabinet as well, in your handbag when you go out, whatever, and you ring them and they'll advise you from there. If you feel like you've got an infection coming, so pain while passing urine, chesty cough, but your temperature is normal, I want you to still call the hotline, the support line, the acute oncology line, whatever it might be called where you are. Still give them a call, because it's much easier to nip that in the bud before it becomes an issue. And so sometimes we don't need to go into hospital. Commonly we do, but sometimes we just have oral antibiotics, and because we've nipped it in the bud. But sometimes you won't ever know. So, like you won't know until it causes a problem. But acting soon. I don't know if I answered the question.
You did. Thanks, Lynn. Thank you. Okay. For Lee, just a short question. Is it okay to have massages?
Oh, yes. As long as the massages, if you have a PICC line or a central line, you have to be careful of where central lines are if you're undergoing treatment. But I think it's important to tell the masseuse that you're on chemotherapy treatment, if you are, or whatever treatment regime you might be on, so that they can adapt the massage accordingly. And it might be that they might not use the particular oils that would be used for people that aren't on chemotherapy, for example. But for sure, it's a really nice self-help thing that you can go and have done. And as long as you're feeling well enough, and it's the right time in between a chemotherapy cycle or in between radiotherapies, it should be okay. Check with your oncology team as well, of course. But I think it's a very good and relaxing treatment, an alternative therapy that sometimes provides people with a sense of niceness, something good to do for yourself.
Can I chip in? Sorry,
Yeah.
you knew that was going to happen, didn't you? So lots of places will have, thinking of the Christie, which not everywhere is the same, but Maggie centres, hospices, cancer, different things might have their own complementary therapy service. So you can tap into them, and they're used to then dealing with some of the fine tuning, if you like, of massaging people who have got cancer or are on treatment. So it's worth checking them out, and also thinking about acupuncture, Reiki, all of that sort of stuff. So looking after the whole self. But yeah, absolutely.
Yeah, thanks, Lynn.
Thank you. Next question is, what are ablation therapies, and is this part of clinical trials? If Lea, are you happy to answer that one? So what are ablation therapies?
Ablation is burning. So I presume, is there any other wording on the question? I can't see it.
No, it's just what are ablation therapies? Is this part of clinical trials?
Right, okay. Lynn,
Yeah. So ablation therapies, I mean, it's a broad term, ablation. So I wonder what we're thinking of here, but it tends to be that they use tools to treat a certain specific area. And it might be that they use, like you say, they might use something that burns it, high X-rays or something like that, or radio frequencies or something like that. Not something that's commonly used in pancreatic cancer as a standard of care, which is why we've not discussed ablation today. And it's not something that's commonly trialed currently. I think it has done and not had great results, in truth. And it would be something, ablation tends to be used in things that are localized disease. So it's not very good at treating numbers of different areas. And you'll remember again, right at the beginning, we're talking about systemic treatment is often the key for people with inoperable pancreatic cancer, because we want to treat the whole body. I always say it's like weed killer for the whole lawn, and ablation and radiotherapy is more like localized treatment. So you're picking up a weed as you see it, if you like. Well, we're actually what we want to do when people have got systemic disease, so metastatic disease, might have stray cells. We want to treat all of the person, and that's why chemotherapy is helpful. So ablation, we do use it in cancer, not commonly in pancreatic cancer, and there's no trials that I'm aware of. We do have a trial finder on our website, which you can take a look at. And like I say, I'd be more than happy to chat, as we all would, on the support line, have a chat with your team. But yeah, not commonly used.
Thanks. And then the question is, what is immunotherapy, and is this part of clinical trials? Lea, are you happy to try and answer that one? Sorry, I'm giving you the hard ones.
Did you say Lea or Lynn?
Lea, I said.
So immunotherapy is giving treatment that will try and get the own immune system, the own body's immune system, to work more effectively, so that it breaks down barriers that stop the cancer, will stop the cancer from growing and from replicating at the rate that it does. So the immunotherapy is given not in pancreatic cancer, but in other cancer types, and that's why we see so much about immunotherapy on the internet, because it's very widely used for lung cancer and skin cancer. But it is the training and the administration of treatments that will promote your own immune system to attack the cancer cells. But it also, at the same time, can attack healthy cells as well. So you can often find that with immunotherapy treatments, there can be other side effects also. I don't know whether Lynn, there are no clinical trials at the moment for immunotherapy.
So no, but it's the things that we're talking about a lot is immunotherapy, and there's some interesting work being done, not so widely in practice at the minute, but it's going to be on the horizon. And but immunotherapy can be given alongside chemotherapy, and it seems to be that is the way that it might go with pancreatic cancer. So you still be having standard of care of normal chemo, inverted commas, normal chemo, but with immunotherapy. But it is an exciting emerging field, to be honest. Yeah, but we've been yet to see the results that we would like in pancreatic cancer, like they have done in lung cancer. You mentioned it's made massive changes there, and we hope for the same.
Yeah.
Thank you. if the oncologist is running a trial and thinks you would be a candidate for the trial, do you think being on a trial has benefits? Or potentially, am I being led to a treatment which suits the trial requirement, or get where this chat
Okay.
Steve is coming from, rather than it being best for me? Any takers?
I don't mind answering that.
Go for
I
it.
don't either, yeah.
Yeah. So it's an interesting question, and I think that the thing with clinical trials, and certainly clinical trials in pancreatic cancer, is that often you are getting standard treatment alongside a new novel therapy. So quite often you may be getting, or you might be having standard treatment that's being used in a different way. So it's difficult, because the unanswered question with the clinical trial is it of benefit? Because that's the purpose of the clinical trial. So, but they should not offer you anything that is not in your best interest. But quite commonly, you should have that discussion there. That would be a key question. You know, is standard treatment more beneficial? But quite often quite often clinical trials might be something after you've had standard treatment and we can't continue with it for whatever reason that might be. And so clinical trials is a good discussion at that point. And I know this isn't the purpose of today's meeting, but that's why a good biopsy is really key at the beginning. You'll remember I briefly touched on the fact that you need a good biopsy to plan treatment, and you also need a good biopsy to have genomic profiling. And genomic profiling can help to identify clinical trials that might be useful for you, and also targeted therapies. But it's again an emerging field. But that's a question that I would definitely be answering if you're about to embark on your treatment or you're on treatment. Did my cancer get sent off for genomics? Because that might help to answer a question about clinical trials or not, next steps or not. I don't know.
Thank you. Okay, so just aware of time. So we've got a few questions that talk about radiotherapy or SABR. So maybe if I ask Lee to take these. So Enya says, we've been offered chemotherapy, but a second opinion doctor wanted to also do SABR. However, the primary oncologist didn't agree with that because of concerns about infection risk. Is this common? And I know this is difficult to remember all this, but the other questions relating to SABR are what comes after SABR treatment? And also, can radiotherapy be given for a tumour on the head of the pancreas after 12 months of trial chemotherapy? So I guess someone's mentioned about infection risk with SABR. Is that common that we would not do that because of infection risk? What comes after SABR? I'll come back to the other one.
Okay. The infection risk is not something that I'm aware of being common, especially with SABR, more so perhaps with the chemotherapy rather than SABR. But no, so my answer to that is it's not that's something that I'm aware of. A second opinion, happy to do SABR around the chemo. It might be, as I mentioned in my slides, that you have 3 months of chemo and then have SABR. And then after this comes on to the next one, what comes after SABR treatment, what tends to happen is that imaging is done around 12 weeks later. It can be a little bit sooner than that, but it really does depend on how you've been after the radiotherapy. But it can take a certain length of time for the radiotherapy results to become apparent. And that's why there can be a little bit of a longer time gap than standard radiotherapy for giving up-to-date imaging. And then it would be based on what the results from that scan are, what the next treatment option perhaps might be suggested. Do you want to add anything to that, Lynn? What comes after SABR?
So no, I would just reiterate that the scan isn't done straight away, because actually you get a lot of inflammation by radiotherapy and SABR. So that's why that's not doing. We need to not scan too soon, because we won't get the full effect. But and it might be that active surveillance is the right thing after. Well, if SABR radiotherapy controls the cancer, we've no need to rush in. We've got millions of things that we can use for pancreatic cancer. There's no sets. It's interesting because you talk about carrying on treatment after you've finished your 6 months of treatment or whatever, or what happens after SABRE or what happens after clinical trials. And actually we need to scan and make that assessment at every juncture. It's not a straight line, which is sometimes feels quite uncertain for people because, you know, it just doesn't follow a set pathway.
Great, thank you. And then that final bit of the radiotherapy question, Paul's asked, can radiotherapy be given for a tumour on the head of the pancreas after 12 months of trial chemotherapy?
Again, good question. Definitely want to ask your oncology team. However, for the head of pancreas, you have the major blood vessels, which are very close by. So I go back to one of my slides, say about radiotherapy, in that it sometimes can't be given because of location of where the cancer is and the size. So it really would be dependent upon those two things, and also what the treatment has been before. And whether appropriate or not. So definitely a question to ask the oncology team.
Thank you. Okay. So this one's for Lynn. Question from Suzanne. Should weight loss be emphasised by the medical staff so the dose can be adjusted in order not to cause further side effects to the patient?
So there's two parts of this. So your chemotherapy is calculated to height and weight. So at the beginning, you may weigh you'll be the same height, hopefully, but you'll weigh a certain amount, and we know weight loss is common. And so you should be weighed at your consultation every time, and they should be mapping that out. And if there's a little bit of an adjustment, you know, like a couple of pounds here and there, we don't get too excited. But actually, if there's been significant weight loss or weight gain, hopefully with all your diet sorted and taking your enzymes, then we do have to adjust chemo doses for that. Yeah, we do. We need to keep an eye on that.
Okay, we've got a question here. We were told that chemotherapy is only a choice, and my father could choose to avoid it and remain with painkillers only, for instance, morphine. Is this approach true and comfortable? Happy to take that one, Lynn?
Yeah,
Yeah.
me? Did you say me?
I said Lee, but
They sound very similar,
They
don't they?
I
do.
do, yeah.
Yeah.
So
Yeah.
yeah.
Do you want me to?
Okay, Lynn, go
So
for
we've
it.
got some confusion here. Right. I'm being harassed by my dog
Doesn't
as well.
take a lot.
No, it doesn't, to be honest. Harsh but fair. So not having treatment is a valid option for people. It may be that people choose not to have treatment, or it might be that the team think that treatment isn't in the best interest for people. So it is something that we should be discussing with everybody. And that's right at the beginning. Again, we talk about having information and understanding the benefits and burdens. So some people choose not to have treatment because the burdens feel that that's not what they want. But sometimes actually it would be not in your best interest to have treatment, because it could make you feel a lot worse, and we want to maintain quality of life. So it's not the most common thing, but it is one of the frequently discussed aspects. And not having treatment is a valid option. It's not a sign of failing or anything like that. So, and thinking back to the slides that Lee shared about, sorry if you can hear my dog crying, the slides that she shared about proactive symptom management of the cancer and things like that. So you mentioned pain relief, but it's not just pain relief. It's lots of other things.
Okay, so Peter's asked, and we haven't really touched on this a great deal, have been focused on my CA99 test results, which have reduced from 1400 to about 70 over the last 9 months. How definitive is that measure? So coming to Lee.
Lee, that's me. So CA99 is really good as a tumour marker. If at the beginning for the levels being 1400 and saying now they're 70, however, it's not just the CA99 that clinicians look at and that you should be solely reliant upon. It's a good indicator, but it is all about your scan, how you're doing, and your most recent scan and what those results show. So it's not a definitive figure. It's brilliant. It's great to see that it's come down to 70, but it isn't the only thing that clinicians will look at. It's the scan and you as an individual and how you're coping.
Someone else has asked a question relating to the CA99. My father's CA99 blood test indicated as normal. The biopsy also turned out normal, i.e. cancer not found. However, MRI and PET scans show growth. Is it true that my father has pancreatic cancer, even though the blood test and biopsy indicates normal? No, that's quite a very difficult question for us to say a great deal on. Do you want to say something, or would it be best just to say maybe they give us a bell or an email and we can talk a bit more?
I think that, yeah, I think that it's
Yeah.
really, we're not able to answer that. But give us a call on the support line and we can think about who might be the best people to ask it to. For me, it needs to go to your nurse specialist or your team and your team. That.
Yeah.
Okay. Teresa's asked, my oncologist prescribes antibiotics and says I should take them continuously. Is this usual? And should I also be taking blood thinners?
Do you want me to say that?
Yes, please, Lynn. Yeah.
Or did you want to do it, Lee?
I would just wonder whether the antibiotics or penicillin perhaps has been prescribed for what reason?
Yeah, we don't know.
Yeah.
Yeah.
Do you want to answer, Lynn, then?
No, because that was pretty much what I was going to say. It would be unusual that people are, unless they've had the spleen taken out, that they would be on antibiotics long term. But every case is different. So, you know, like we have given people, we might give people antibiotics to take if they're on FOLFIRINOX with the irinotecan, the ciprofloxacin, to take if they've got any problems with diarrhea. It wouldn't be continuously. So it's definitely absolutely a question for next consult or the nurse specialist in between. Again, it's very specific to an individual case, so it's very hard for us to answer that fully.
Okay, and then the last question on the Q&A, not really completely relevant to what we're talking about, but I would like to give an answer. Gemma's asked, my mum has pancreatic cancer and liver cancer. She takes enzymes before eating. Will it help with a cup of tea? She asks. So I know that we would like to say something about that. Lee, do you want to say something?
Yeah, absolutely. So enzymes don't necessarily all need to be taken before eating. It's best to have them with the first mouthful and spread them out throughout the meal. And will it help with a cup of tea? Not to have it with a cup of tea, because ideally you must have it with a cool drink or something cold, not hot. The reason being that it can deactivate the enzymes in the wrong place, so it might as well not bother having them. But if it's okay to have a milky drink or a hot drink after having enzymes, and if you're having, say, something like a milkshake, so something that's got high content of milk, you need to take enzymes with that. I'm not 100% sure exactly whether the type of tea, if it's a chai tea, then obviously if it's cooled down and it's cool, absolutely you probably need, if that's been made with milk, especially full fat milk, you'd need to have enzymes with it, but not when it's hot.
Unless you're having chocolate biscuits with it, which I would highly suggest that you are with your teas and your coffees. But definitely, if you're having a chucky bicky, then absolutely have some enzymes.
Yeah.
Can I jump in and ask a question? Is that all right that I've seen in the chat?
Oh, okay. Yeah, we haven't got too long, but
no, I'll keep it very brief, which I know is not like me. But I will. And if I don't answer it fully, or we're not got time to answer it fully, I would advise it's Paul. Give us a call on the support line to have an in-depth chat about diet and digestion. To be honest, so it's like struggling with digestive issues, FODMAP diet, which has helped greatly. He's also having vital nutritional drinks, much better than do you need to enzymes with these drinks? So yes. So on the whole, you need to have digestive enzymes. I don't know these specific nutritional drinks. I'd have to have a look at them. But nutritional drinks tend to have fats, proteins, and carbohydrates. They're nutritionally complete. and digestive enzymes help you to digest fats, carbohydrates, and whatever the other one, protein, whatever I said.
Protein.
And so not often we recommend a FODMAP diet, but what I would say is you do what works best. As long as the weight is stable and we're not losing weight, then fine. And take enzymes with everything practically that you have. But to answer that in more detail, give us a bell.
Okay, thanks very much. Great, so we've got through all those questions. Great to see lots of questions coming in. So thank you so much for participating in that. So yeah, we've pretty much come to the end of our session this evening. So before you go, say a really big thank you to Lynn and Lee for sharing your expertise and useful guidance with us this evening. I also want to give a special mention to thank Claire and Bradley for sharing their experiences. And finally, I'd also like to say a really big thank you to you all for coming, taking the time to join us this evening. As we've mentioned lots and lots, we work on our support line, and we would be really thrilled to chat to you more about your personal situation, because we know that can be really helpful. But on behalf of me and the team at Pancreatic Cancer UK, thank you so much for coming, and we really hope it's been useful for you, and hope you have a lovely rest of your evening. So goodbye for now.